Hi friends, I am Dr. Sandeep Suri, working as consultant diabetologist at Holy Health Hospital, Hisar, Haryana. So today I am going to talk about the combination of empagliflozin and linagliptin and how this is benefiting and how this combination has got promising results, promising benefit in CKD perspective, like chronic kidney disease perspective. And many times we have been asked a question, can you elaborate on various mechanisms behind renal protection of SGLT2 inhibitor in type 2 diabetic patients? What are the clinical implications of renal outcomes of CVOTs of SGLT2 inhibitor and also of DPP4 inhibitors? How these are things are related to real world evidence, whether these are only in RCTs, whether these can be replicated in real world evidences. So let's go in bit detail. Friends, diabetes is a strong risk factor not only for cardiovascular disease but also for development of CKD. And with further worsening as the occurrence of CVD risk in diabetic patients. Approximately 40% of our patients with diabetes, upon screening, even when they are asymptomatic, they had decreased EGFR and also they have got albuminuria evidences. Because of unique mechanism of SGLT2 inhibitor, we have a range of benefits that may translate to potential benefit beyond glycemic control. So by using these molecules, we have moved away from glucocentric approach that we used to have beyond before 2015. Glucocentricity has moved on to organoprotection, and we are looking at cardiorenal metabolic or cardiorenal conundrum. Plus, we are having now patient-centric precision medicine approach by using these two class of molecules. Because why we have clubbed cardiorenal conundrum together? Why we say it? Whether these are two organs, why they are linked together? Actually, these two organs are inseparable. They are just inseparable because of lots of crosstalk that goes on between myocardium and renal tissue. So these two organs are inextricably linked with each other. And that's why we can see that all CVOTs have got a renal endpoint, maybe it is secondary hypothesis generating or exploratory endpoints. And then we had renal endpoints directed trials directly looking at renal endpoints. Plus, we had also the evidence, we looked at evidence for CV benefit in these trials. So all these CVOTs with SGLT2 inhibitor class of molecule, irrespective of CV benefit, whether you had 3-point based benefit or not, whether you had got CVD benefit or not, or all cause mortality benefit or not, irrespective of the population studied, we had from SGLT2 inhibitor class of molecule, renal benefits was exactly it was shown as a class benefit, both in the format of declining EGFR and also stabilizing EGFR. That means it prevented declining, going down of progressive decline in EGFR and also worsening or development of albuminuria. So all these results of renal benefits are overwhelming even from the SGLT2 inhibitor class of molecule. So why this is happening? Because of pleiotropic effect. Because of pleiotropic effect, there is decrease in blood glucose, that is one thing, natriuresis, decrease in blood pressure, decrease in weight, and other protective effects which we are going to just discuss. EMPA-REG outcome trial was the was the pivotal trial of empagliflozin that was done in 2015. And this trial was the main turning point in our perspective of management of diabetes. And that has clearly turned the whole scenario by 360 degree when you looked at how we used to manage diabetes. That was a randomized control trial, double-blind, placebo-controlled phase 3 trial involving 7020 number of patients. Almost all of these patients were having established CVD. They had mean EGFR of 74 mils per minute, and they had got mean urinary albumin creatinine ratio of 18 milligram per gram. So that much, not much deteriorating renal profile was there. So, but these renal endpoint was secondary hypothesis generating endpoint. So pre-specified secondary renal outcome of this study included incident or worsening of nephropathy. That means progression of progression to macronuria, doubling of serum creatinine associated with EGFR decline, and doubling of serum creatinine. The main driver for reduction in nephropathy with empagliflozin was slower progression to macronuria. So that was the excellent benefit we had with empagliflozin, 38% reduction in progression to macronuria. Then it was significant reduction in worsening of nephropathy or CV death by 39%. Progression of macroalbuminuria decreased by 38%, and then initiation of renal replacement therapy was decreased by 55%. So that was important thing. You had lesser worsening up to the tune of 35 to 50%, no requirement of renal transplantation, no requirement of dialysis. So that was the benefit. Around 55% patients were not showing any requirement of renal replacement therapy. And these that there was no difference reported between two therapeutic doses like empagliflozin 10 milligram and empagliflozin 25 milligram. So again, there was a benefit that renal benefits can be seen even with lower doses of empagliflozin. And importantly, in EMPA-REG outcome study, empagliflozin decreased new onset or worsening of nephropathy by 39%, and that was done on top of RAS blocker. ACE, ARBs, they were already there. We had ACE-ARBs, we had a renoprotection from GLP-1 receptor analog, we had benefits from DPP4 inhibitor. How they are different in comparison to SGLT2 inhibitor? Actually, SGLT2 inhibitor, they decrease progression from normoalbuminuria to micro and progression from micro to macro. Whereas ACE, ARB, and GLP-1 receptor analog and DPP4 inhibitors, they decrease progression from micro to macroalbuminuria. So the exact benefit that we wanted was achievable only with SGLT2 inhibitor class of molecule. The CV and renal benefits seem to be maintained independent of baseline EGFR. Even with progressive EGFR decline, we had benefit in CV benefit. And all, if you remember, all these renal endpoint trials like DAPA CKD and also Credence trial, and we are waiting for EMPA kidney trial. But these, and also EMPA kidney trial is showing that it is going to be stopped early because if it is positive result. Same thing happened in Credence, same thing happened in DAPA CKD, that before, just say half year or 1 year before the stipulated time, we had enormous amount of positive results. That's why we have to stop these trials in between prematurely, looking at the overwhelming benefit we had from CV endpoints and also from renal endpoints. Then from EMPA-REG outcome trial, another thing that was important to highlight, at the end of the treatment, more patients improved from macroalbuminuria at the baseline to microalbuminuria. That means reversal of macro to micro came in 32% of patients. From microalbuminuria to albuminuria, normoalbuminuria. That means just normal albuminuria was achievable in 22% of patients. There is slight transient decrease in EGFR as per the modality, as per the mode of action of these molecules. I'm going to highlight just within few seconds that there is slight initial decrease in EGFR by 20%. That is normal way of mechanism. And after that, within 4 to 6 weeks, there is stabilization and there is stabilized EGFR that persists throughout the trial period. So that initial dip can be there. And why this happens? Because these molecules, they act by improvements in tubuloglomerular feedback mechanism. They decrease intraglomerular pressure by fine-tuning the efferent tubules. They constrict small amounts constriction can be there in efferent arterioles, and it is due to adenosine-mediated effect. By having more sodium going to macula densa, there is improvement in tubuloglomerular feedback, and that leads to decrease in single nephron GFR. That's why there is initial 20% dip in GFR in most of these studies, and that showed that this dip indicates the molecule is working, and then this EGFR gets stabilized and it persists as such without any further deterioration. Now, why this is happening? Then we looked at various mechanistic studies. One thing that came out, ketone bodies. That means fuel hypothesis or superfuel hypothesis. The ketone bodies are formed as per the mechanism of action. There is the physiologically increased glucagon level, and then also there is decrease in insulin level. There is decreased requirement of insulin goes down, glucagon goes up, and there is more lipolysis, and that leads to, due to this glucosuria and due to calorie loss in urine, this leads to ketone body formation, and ketones are basically superfuel. They leads to decrease in renal oxygen consumption. Also, they are beneficial, and this milder ketosis or physiological ketosis is also beneficial for myocardium. This may be protective for renal and also for myocardium. So there is a superfuel theory that comes here. But importantly, these molecules work through tubuloglobulin feedback mechanism. Also, there is the benefit is increasing erythropoietin. Also, there is benefit in proximal tubule getting offloaded, and there is the better oxygenation of proximal tubule that leads to decreased inflammatory stress, that leads to decreased oxidative stress in the interstitium, decreasing fibrosis and better renal physiology and also better renal pathology. So that's how these molecules are working. But importantly, we don't have one theory that to explain the overwhelming benefit in renal outcome with SGLT2 inhibitor class 1. Now, what about the other co-partner, that is linagliptin, that is being used as a fixed dose combination with SGLT2 inhibitor? Linagliptin has shown benefit in Carmelina trial, and there was a mechanistic study associated that showed there is decreased podocyte apoptosis. Podocyte apoptosis, that is one of the key feature of diabetic kidney disease, and also due to this enhancing insulin signaling. So that was another issue that showed that this molecule is beneficial. Convert and showed there is 14% reduction in progression of albuminuria. That was the significant finding in linagliptin trials of Carmelina trial. And also linagliptin demonstrated that the molecule is CV safe. Also, the molecule is renal safe, but added advantage, there is 14% reduced risk of progression to albuminuria, progression of albuminuria, specifically from micro to macronuria. Worsening of albuminuria was much more lower, significantly lower in linagliptin arm in comparison to the placebo arm. Another unique thing regarding linagliptin, it is metabolism. Its metabolism or route of elimination is hepatobiliary in 95% of the time. 95% it is hepatobiliary, only 5% it through the renal metabolism. So what does this mean? That means you can use linagliptin as such 5 milligram dose throughout the whole spectrum of renal disease, even up to ESRD, even up to hemodialysis. And another thing that is very important, you need not to alter the dose. That is one aspect. Another thing is that as your renal parameters are deteriorating, the molecule is showing the benefit in HbA1c, retained benefit. That means 0.7 to 1.2% reduction in HbA1c from ESRD and hemodialysis patient, and even in new onset diabetes after renal transplant, the molecule is showing benefit. So this is renal safe and also renal protective. So till now, we had results from DAPA CKD and also from CRIDL. So these two are basically showing that these drugs are working, specifically DAPA CKD showing benefit in renal parameters, both in type 2 diabetic patients and non-type 2 diabetic patients. But they were proteinuria. Similarly, credence showed benefit only in type 2 diabetic patients, very high risk type 2 diabetic patients, but they were significantly proteinuria. So we had answered that till now, SGLT2 inhibitor class of molecule are working only for proteinuric diabetic kidney disease or non-type 2 diabetic proteinuric kidney disease. So we are waiting for AMPA kidney. AMPA kidney trial is basically has enrolled more than 6,000 patients, and those patients are having type 2 diabetes and non-type 2 diabetic patients and also type 1 diabetic patients, but they are with or without albuminuria. So they have expanded the bandwidth of SGLT2 inhibitor class of molecule by AMPA kidney trial, and the preterm or the press release by the investigator is that this trial, AMPA kidney trial, is very significantly showing the benefits, and maybe it is terminated as early as going to be terminated prematurely and showing the benefit even up to eGFR of 20 mils per minute. So friends, the whole spectrum is very different. It is increasing and it is improving like anything. Whole gamut of the benefits of the renal endpoint has been definitely changed by, say, you can say what we had, say, 1.5 decade or 2 decade back. We had only ACE inhibitors and ARB. We have to treat glycemia, we have to manage hypertension, we have to take care of risk factor, and we had only ACE and ARB. But now you have a molecule which is showing SGLT2 inhibitor class of molecule, which is showing whether patient type 2 diabetic or not, whether patient albuminuric or not. This molecule is showing even up to 20 mils per minute EGFR, nephroprotection, requirement of renal transplant, renal replacement therapy going down significantly up to the tune of 35 to 50%. So very significant finding in CKD trials that has been shown by this class of molecule, SGLT2 class of molecule. Then cannot forget linagliptin showing benefit among all gliptins. This is the molecule which is nephrosafe, but also protection for albuminuria. Thank you for the patient.